Welcome, everyone, to Rush University Medical Center Division of Nephrology Renal Biopsy Conference for August 24th, 2023. We've been off a couple of weeks, but we're back and we'll keep this going. It's now interview season. I'd like to welcome our interview candidates on the Zoom today. We'll be talking to you later, but welcome. Hope you enjoy it. Rest assured, we will not call on you. You're not on the, excuse me, you're not on the wheel. It's 100 degrees outside, and it's about 98 in our offices because our air conditioning is not really functioning. So if any of us passes out, just if you see us slumping, just call 911. It's pretty miserable here. We don't have an activity code today. Our disclosures, we as usual have nothing to disclose, and as usual, we have a privacy statement that de-identifies anything to do with the patient, ethnicity, exact laboratory values, etc. I've got a very interesting case today of Dr. Baxey's. I think we're all going to learn a lot from this. I have and am still learning from it. With that, I think we'll hand it over.
All right. Yeah, it is very hot. So there's a glitch. It's not Zoom, it's me. So case presentation, I just want to make a note. This is 15 years ago. So this case is 15 years, you'll see why we have follow-up, and just kind of put your mindset of how you would think about this 15 years ago. So I had a 25-year-old Hispanic woman who presented via her PCP for workup of hematuria, and she had non-nephrotic range proteinuria. No other medical history, very otherwise, healthy. She was setting up just a annual exam, and she was found to have hematuria and proteinuria and a UA. She had no symptoms. She was not taking anything else over the counter. She's never noticed hematuria. I mean, she never had gross hematuria, really no other urinary complaints, no flank pain, nothing of that sort. Denied any major childhood illnesses. The only thing she had was a history of prior recurrent UTIs, but none at the time of evaluation. She was not on any medications. Social history, really not remarkable. She did have an uncomplicated pregnancy 3 years ago, end of C-section, but otherwise baby healthy, no other medical issues during the pregnancy. Family history, nothing in the record. Vitals 100/70, normotensive, afebrile, weight 76 kilos. On exam, really nothing to note of. She was well appearing, looked her age, very healthy. No cardiac or lung abnormalities, no rashes, no edema. So on her initial evaluation in terms of lab work, she had, and that's all listed here, of note, her creatinine was normal at 0.8 milligrams per deciliter. She had an albumin of 3.9. LFTs were normal. White count was within normal limits with a normal diff, hemoglobin 12.4. She had a MCV of 82. She did have low iron sat and low ferritin. The coags were normal. ANA, anti-double-stranded DNA, C3, C4, SSA, SSB, all done as part of the initial proteinuria hematuria workup, was all negative. MPO, MP3R were also negative at that time. Microbiology was also done. Again, nothing remarkable. Hep B, Hep C was negative, HIV negative. And the UA had microscopic hematuria and dipstick proteinuria. And looking back at her prior records, her creatinine had been normal, albumin had been normal. And when we look back at her UAs, this hematuria and proteinuria had been dating back at least 5 years. Now, this is somewhat hard to interpret because at that time she was having recurrent urinary tract infections, and she did have positive urine cultures that were treated with symptoms from what we could tell in the notes. But this was noted at least 5 years back from the initial presentation. The UA at the time of the nephrology visit, 2+ protein, negative glucose, large blood, 40 RBCs, 0 to 3 WBCs, and her UAC was 1.8 grams per gram with a corresponding UPC of 2.9. And that was pretty consistent with the prior value that prompted her initial referral. Renal imaging was done. Right kidney was 12 centimeters. Left kidney was 12.1 centimeters. No hydronephrosis. There was no increased echogenicity. And a kidney biopsy was recommended and performed.
Any questions? Pravir, how old was she at this? Remember, everybody, this is 15 years ago. It's probably, for some of the people on here, they were in grade school or even high school. Hard to believe, but she was 25 at the time. Thank you.
25.
Okay.
Yeah.
Any other questions for Dr. Baxey? Okay, let's move on. We're starting with a poll. So for these people that are new, we always like to see what people think before we show the results, and we discuss it quite a bit. So what do you think this patient has? IgA nephropathy, thin basement membrane disease, focal sclerosis secondary to chronic reflux, lupus nephritis, or ALEC2 amyloid?
Sorry, applicants, we can't see what you chose. It won't go into any of your interviews. So as we say. I do see what Hamoud's doing now.
We have a spy on Hamoud. Spy cam. So everybody vote. And like Pravir said, we don't know what you're voting. So we like to see what everybody thinks.
All right.
Sometimes we're tricky, sometimes we're not tricky, but we don't really try to trick for the sake of tricking. We try to give a reasonable differential diagnosis based on the presentation. Ironically, sometimes we even miss something. So here's what we've got. We've got the highest is IgA nephropathy at 57%, thin basement membrane disease, 24%, focal sclerosis, 9%, lupus nephritis, 4%, 2 people, and 3 people picked ALEC2 amyloid. So kind of a good smattering of thoughts here. Why don't I hand it over to one of our faculty and see what they think of this differential diagnosis. Casey, you want to take it over and tell me what your thoughts are?
Yeah, I kind of like the order. I was thinking a young Hispanic female with proteinuria and hematuria could have all of these things, but I think statistically and from just a total number standpoint, I think IgA nephropathy is still probably most common. Thin basement membrane, I usually think of it as maybe more hematuria, a little less proteinuria than what she has, but these are sort of basement membrane diseases, such as, for example, like could be on the spectrum of like Alport. So these are, from nowadays perspective, these could present with subnephrotic range proteinuria. So that's also on the differential. And I think really a biopsy is how you decide which one it is. I haven't really seen any evidence of, either frequent UTIs or any imaging evidence of reflux, but I suppose
she had a history of UTIs in childhood.
Did she? Okay, all right. Then I guess in that case, and imaging wise, did she have any abnormalities on her ultrasound? Not really.
Nothing impressive.
Nothing on the ultrasound. So I don't know. That's possible to have that. Lupus nephritis in a young female. I know her serologies are negative, ANA is negative. That's makes it less likely. However, you can have some renal manifestations before you get systemic lupus. That's rare, but happens. So not completely out, but ANA double stranded being negative. She has no really systemic symptoms. That's probably less likely that she has lupus, but she could have sort of like nephritis prior to systemic disease. Electro amyloidosis. She is Hispanic, so it's possible. Subnephrotic proteinuria, usually that tends to be tubular interstitial in nature. For bicarb 22, I don't see any electrolyte abnormalities. So if it is, it's pretty mild. Let me see, yeah. BU112, bicarb 12, potassium 3.5. So it seems like she's okay from a electrolyte standpoint. So again, possible, but less likely. I'm still going with Dr. Reen said family history. I clearly have not been listening. Did she have a family history of kidney disease?
No, there's no history.
Okay.
It was never. We went back to the record. It's never mentioned. There's no mention.
Anything.
So it's not that we don't know. We just don't know.
We don't know. Okay, so I think this is statistically still going to be IgA. We are now sort of thinking about complement mediated problems in patients like C3GN, MPGN, things like that. Again, the complements are normal. These are all less likely. I think I'm going to go with IgA as my number one.
And you brought up the ALEC2. We try to put these in there for a reason: Hispanic and some proteinuria. But you're right that ALEC2 is amyloid is more of an typically an interstitial disease. And you brought up the electrolytes. I'd point also out that her albumin creatinine ratio is about 60% of her total protein-creatinine ratio, which doesn't really fit a tubular proteinuria profile, going along with what you were saying too about the electrolytes not supporting a tubular interstitial disease. Dr. Reen, can I ask you to tell us what you think is going on and a little bit about your differential and why?
Oh, I think I tend to agree with Dr. Beshti. My first diagnosis will be IgA nephritis, but I will also think about thin membrane disease, although they call it autosomal recessive disease now. And that I'm thinking quite strongly because although you don't have any family history, but I think that should be reviewed. Hispanic being electrolytes is a possibility. Because of interstitial pattern of disease, subnephrotic proteinuria, she's a Hispanic. Other thing, lupus, I didn't think it would be the cause because it does not fit the picture of, there are no serological or clinical signs of that. And you could make a case of non-lupus full house nephritis, which I doubt very much she will have because the proteinuria is not that high. So I'll go with thin basement membrane disease, IgA, and third will be my electrolytes being Hispanic and subnephrotic proteinuria.
So you're putting IgA top or thin basement membrane? I'm sorry.
Thin basement is my first diagnosis.
So that's interesting because, you know, Casey made a point, you know, it tends to be more of a hematuria disease and a proteinuria disease, although clearly it can be, and some of the original reports in New England had some fairly high protein, but typically we think of it as predominantly a microscopic hematuria disease. And this patient's got 3 grams of proteinuria, and I think that's, I find that unusual, and I find it a little odd that you would have put that as a top over IgA, which this is what kind of screams to me, Hispanic with hematuria, proteinuria, and the like. So can you defend, can you further defend your thin basement membrane?
I personally don't think I should call it thin basement membrane.
Well, I'm going to interrupt you here because this is 15 years ago, and that's what we called it back then. So put yourself in a time capsule 15 years ago, and okay, you're only allowed to call it thin basement membrane today.
Yeah. Okay, I'll say thin basement, but I wouldn't be surprised she turns out to be some sort of cola for collagen disease, such as Alport, either Digenic or autosomal dominant. So that's the way I'm thinking, because this is that is a possibility. I would have thought IgA nephritis would have gotten worse by that time in a Hispanic girl for 15 years. So I'll still stick with that.
Well, we don't know. This is 15 years ago. You don't know what happened.
Oh, sorry, I didn't know that. Okay.
Yeah. So this is 15. This is 15 years ago. We don't know what happened. We have no follow-up. She's just sitting there.
Okay, so IgA.
This is her first presentation.
IgA, possible hereditary nephritis from, although we don't have family history. I hope you tell us family history in the follow-up. So that's the way I'm thinking.
Got it. Dr. Corbett, what do you think's going on?
I think everybody's covered the differential pretty well. You know, there are these patients that have thin basement membrane nephropathy, have more proteinuria and sometimes CKD. And when they biopsied them, they found that not only do they have thin basement membrane, but they also have an underlying FSGS, which may account for why they have more proteinuria, so that there's another lesion kind of coexisting. And then the idea of IgA nephropathy is, you know, high up on the list, given the hematuria, proteinuria, and even what up to a 20% of people with IgA nephropathy can have thin basement membrane nephropathy coexisting with that. Yeah, I don't think this is lupus. I definitely don't think it's ALEC2. I think it could be, as we've talked about already, some combination. And then you get into this whole issue as Reen's brought up about, you know, autosomal Alports. This whole area just seems to keep expanding. And then actually, he just brought up the issue of Digenic Alports. There's a great review from November of 2022 that I finally caught up on a few weeks ago. And not only is Digenic autosomal recessive, it can be autosomal dominant as well. I mean, the alpha 3 and alpha 4 are on chromosome 2. And if both mutations are on the same chromosome, then it's autosomal dominant. If they're on 2 separate chromosomes, in other words, you have an alpha 3 mutation on the chromosome 2 one chromosome 2, and on the other chromosome 2, you've got an alpha 4 mutation, so it's digenic. Those get passed on as autosomal recessive. So this whole area has just gotten more and more intriguing. I have no clue if that could be going on. We have no real family history, which would have been helpful, but I think, I think it's going to circle around, the top 3 diagnoses that are on here, and I think that they could coexist. Like I say, thin basement membrane with this kind of proteinuria could be FSGS or associated with IgA. For FSGS to have that kind of microscopic hematuria, 40 red cells, is not that common. I mean, you have a little bit, but you don't have, that kind of hematuria. So I'm going to go with thin basement membrane nephropathy plus, say, FSGS.
Yeah, and you're the champion of reflux and VCUG. So if you're not jumping on that bandwagon, it must not be very strong, because you like that diagnosis. I think we should spin the wheel and see what the pathology shows here. Okay, oh great wheel. Tell us, who shall read the biopsy today? Dr. Corbett.
All right.
Oh boy.
And give me a second here, Steve. I'll give you control.
The temperature in this room just went up another 5 degrees.
Yeah.
I got a fan on me. I'm cool.
Oh, lucky. All right. Should be able to click on the screen. Yep, that's you controlling it.
All right.
One more time.
Looks like it's downloading something.
Go ahead.
Okay. All right, so we have a low power Trichrome. Looks actually quite good. Is David on with us?
Yeah. Can you hear me okay?
I do now. So it's a low power Trichrome. It actually looks quite good. I mean,
Yeah.
tubulars, interstitium look good. I mean, there's minimal, if any, fibrosis. And the glomeruli, at least at this power, all look good. I don't even see one globally sclerotic one.
Yep.
All right, doing well so far. Here we've got an H&E. Again, this glomerulus looks really pretty pristine. Capillary walls look nice and thin and delicate. The mesangium really isn't that expanded. Maybe in a couple little areas you might have a few too many nuclei, but the majority of this glomerulus looks normal. The tubules look good. We do see some red cells, but these are outside of the tubules, aren't they?
Yeah, they're in the peritubular capillaries,
Yeah.
just some unlicensed red cells.
Fair enough.
Yeah.
So this looks, I don't see anything here. Do you, David?
Yeah, I agree with everything you said. Looks normal.
2 for 2. PAS, again, this looks quite normal to me. I mean, again, mesangium in general looks normal in cellularity as well as in volume, and the capillary walls look good as well. I mean, brush borders look very nice here. There's a distal tubule, another proximal tubule brush border. This all looks good.
Yep.
Consistent with, the creatinine of whatever it was, 0.8. And we don't really see anything in the way of protein reabsorption droplets there. And even on the Jones stain, we don't really see any protein reabsorption droplets. I forget, it was like urine protein creatinine ratio was like almost 3 grams. This looks like a mitotic figure here in the tubule, but again, no protein reabsorption droplets. And you look at the glomerulus and you see one of the arterioles coming in here at the hilum. On FOS, you don't see any holes in the basement membrane. You definitely don't see any spikes or splitting. Again, this looks normal to me.
Yep.
So don't advance, Steve. What are you predicting the IF will be?
Well, it could still be IgA. It could be thin basement membrane, which would be nothing. Because even
Now, I would think if it were an IgA enough to have 3 grams of protein out, I would expect some mesangial something. You agree or
I
no?
thought you were asking me.
I am asking you.
Then I
But
can
you-
ask-
but you
I guess I'll
hesitated.
ask you, what do you think?
You hesitated.
I was thinking. No, I agree. I mean, I would expect with IgA to see at least some mesangial expansion. You don't have to, but I would think you would, and I don't disagree with you. You would think there'd be, a fair number of deposits which would go along with the expansion if they're having this kind of proteinuria, which kind of, then as we were talking before, to see this with just thin basement membrane and have that kind of proteinuria is kind of unusual too, unless there's something going on with the podocytes that, that we didn't really even talk about, like a minimal change like disease, because we definitely haven't seen a segmental scar anywhere along the way here. So what do I think the fluorescence, I guess, now you've influenced me. The fluorescence will be negative. I don't even know. Is that what's next, David?
Yeah.
Oh. Negative. So no IgA, no IgM, no IgG. So that takes IgA right out of the equation. And here we go with the electron microscopy. Nice low power, but you can see this capillary loop here. There's a mesangial area here that's a little hard to interpret just because it's dark. It's off into the left there. And then
Can you just orient the blood and urine space for the,
sorry,
everybody's not.
Urinary space is out here. Blood space is here. Here's the endothelium. Here's the basement membrane, and a higher power, which I hope we have, it'll be easier to see. And then out here are the foot process or the podocytes. If you got a higher power of this, David,
Yeah.
let's go to a higher power, right? I don't think there's really anything here to point out it. All right, here we go. Urinary blood space. Out here's the urinary space. Here you can see beautifully the fenestrated endothelium here, the basement membrane, and out here are the podocytes. There's a little focal effacement. The basement membranes are definitely thin. They're less than 250. I see no deposits whatsoever in this loop. Over here, this other, here's another loop here. Here's the endothelium. Again, focal effacement, no deposits. This is kind of getting into the, I assume, the mesangial area. The basement membranes, again, are quite thin here as well. So not surprisingly, there are no deposits. We haven't really seen the mesangium, but I wouldn't expect to see any there either, given the fluorescence. And this is all going along within basement membrane thus far with some focal effacement. Here we go again. Here's what's left of a capillary lumen. Here's the urinary space. I don't know if this is Bowman's capsule out here.
Yeah, that's Bowman's capsule.
And
Yeah.
there's a podocyte, I guess, right here, because here's the foot processes. Again, these foot processes look quite nice. A very thin basement membrane is, and then the fenestrated endothelium. And what you can see, the mesangium over here is there are no deposits.
Yeah, so I did the type for the
It's always looking for
Alpha.
Alports. So
yeah.
alpha 5 chain should stain capillary walls, Bowman's capsule, and the distal tubule. And sure enough, it seems to light up.
Yeah. This is normal.
I was just going to say, it's not a mosaic for sure. I mean,
No.
I was starting to wonder whether we have a mosaic pattern here, but I assume it's not. I mean, the distal tubule is
This is
lighting up.
normal in our lab. Yeah.
And the alpha 3 is positive, is lighting up as well. So at least X-linked Alports is pretty much out of the equation. And I don't know that it was really considered seriously to begin with. Even though, I mean, I guess it could have been, we had no real family history. It would be kind of unusual to be, what was she, 25 years of age? Well, yeah, women don't necessarily have to have that much in the way of chronic kidney disease if they're mosaics. They can have proteinuria and hematuria and not much else.
I have two women on dialysis with Alports.
Pardon?
I have two women patients that are ESRD from Alports.
Oh, no. We reported, Priya
Yeah.
and I reported a number. It can happen. I mean,
Yeah.
no question it can happen. It just depends on how many X chromosomes are turned off with the mutation or turned on with the mutation
Of their kidney.
That's right.
Yeah. So
So-
Steve, so you could only use terminology 15 years ago. What would your answer be 15 years ago?
Thin basement membrane nephropathy.
Exactly. And I kind of stress that because, you know, it's been brought up, there's a whole nomenclature change and we'll probably get into that, I assume. But it is important. Go ahead.
Right. I mean, you know, Cliff Cashton and that group with Alports came up with, I think it was 2018. They redeveloped the classification where they want to get rid of thin basement membrane and call it autosomal Alports, primarily with the idea that the assumption is if you give them a diagnosis of thin basement membrane nephropathy, it historically would imply a benign course, and that's not always the case. In fact, as we've talked about before, Alports actually, their initial lesion is thin basement membrane, and then it evolves from there.
So we're going to get a little more story here from Dr. Baxi.
So moving forward 15 years, for me, that means med school finish, residency finished,
I was
fellowship finished.
I was old 15 years ago. I'm 15 years older now. But you guys were all young. Steve and I were both old back then. By the way, I'm glad the wheel went on you, Steve, because I know you've always had an interest in I know you've written about this and you've always had an interest in these stains and the genetics of it. So I'm kind of glad the wheel went on you. I'm sorry, Pravir.
So 15, fast forward, she follows up again with her primary care doctor. And after this biopsy, she was started on an ACE inhibitor. I'll start there actually. And she never followed up with the office. She would follow intermittently with her primary care doctor who was refilling it. And then at some point, you know, the primary care doctor finally convinced the patient to say, hey, you really need to just set up for nephrology follow-up. And that's when I entered. In the interim, she had another pregnancy, successful C-section. Again, she had no other complications during the pregnancy, no hypertension, no worsening proteinuria, no preeclampsia. The baby again was okay. When I saw her, I asked her about her ACE inhibitors. She admitted she was taking it very intermittently, not regularly. She had gained a significant amount of weight, I think 30 pounds at least since the biopsy over the course of 15 years. No other new medical issues, no diabetes. Her blood pressure was still controlled, was not taking any other medications outside of the intermittent use of an ACE inhibitor. And when I saw her, I finally tried to get a little more about her family history. And sure enough, her mother and her father both had what she said was hematuria and proteinuria, but without any kidney disease. She mentioned that. So that's a new element of information we were able to attain. On labs, when I repeated them, her creatinine was still 0.8, fortunate enough, and her albumin was still 3.6 to 3.8, so still normal. Her proteinuria had gone up to 3.5 grams. Next slide. So I made sure I told her at least restart the ACE regularly. I upped the dose to the max dose and encouraged weight loss, which she was on board with, and she lost weight. And even then, repeat follow-up lab showed her creatinine was stable, albumin was stable, but proteinuria was unchanged. So our next poll is, what would you do now at this point on follow-up?
Would you repeat the kidney biopsy? Would you add SGLT2 inhibitor? Would you do genetic testing? Or basically, she's done fine, nothing, just follow her closely? We may have hit a new record of participants today in the 70s. Thanks for joining, everybody. I guess they knew it was Dr. Baxi presenting and they had to join on.
Yeah, you blew Bill Whittier out of the water on this one.
Yeah, you know, happens.
NBD. All right, a few more. All right, we'll end the poll right there.
So about 14% wants to repeat the kidney biopsy. 30% say, hey, let's just throw them on an SGLT2 inhibitor. That's everybody gets that these days for everything. The majority of people at 51% say genetic testing, and then there are a few people that said, you know, the patient's doing fine, we'll just follow closely. And with that, I want to hand it back to the faculty and say, let me ask Dr. Reen now, what do you think about all this? And
well, I'm I'm torn between B and C. So I was initially, when it was I was thinking that I will add glucose transport inhibitors to renin-angiotensin blocking agent. I do think it's a sort of thin basement membrane or a carrier state of a variant of Alport syndrome. And there are cases which have been described with proteinuria in these cases. But a lot of new things that come, there are some studies going on nowadays. So I changed my mind to genetic testing. So I will suggest genetic testing.
And I'm surprised that you would even hedge, because your whole differential at the beginning was based on understanding the genes and the changing terminology and the changing understanding of the genetics of this. So you ended up with that answer, but I'm surprised you would even, it wouldn't have been very obvious to you, because you were the champion to start from thinking about a genetic disease. Casey, what would you do here?
I'm trying to think how that would change how I manage the patient.
Well, let me just say that these are not mutually exclusive. You could genetic test, or you could add an SGLT, but we're just saying right now, the first thing you would do.
Yeah, so I mean, with the family history added, and yeah, I mean, so let's say the patient has Alport's or thin basement membrane. Let's see if you do genetic testing and she does have an abnormality in her alpha 3 or alpha 4. Would that change how I manage her? Yeah, I mean, like you said, genetic testing is 1 tube of blood nowadays. Is so easy and cheap. Why not, right? Why not see? But are you going to change management by doing so? I'm not really sure. Maybe when it comes to transplant, I mean, she has her own internal control of 15 years of really not being even treated, and she's done okay. Gained some weight, but otherwise okay. She's not really taking ACE inhibitors that much anyway. So if you put her on ACE inhibitor consistently, maybe she'll have less proteinuria. So I'm going to go with genetic testing, but again, I don't think that will change anything.
Dr. Friedman in the chat says Digenic / biparental, and hopefully that's something that can. It's a really interesting thought, and he's always smart. I gotta admit, he doesn't say much, but what he does is awfully smart. But we'll see if Pravir can go into that. And I think that, Dr. Reen kind of alluded to some of that too, this whole Digenic thing, and Steve even brought it up. So, I guarantee you 15 years ago, that was not going to be anybody talking about that. And Steve said it was a fairly recent paper that he read and kind of put him really in touch and up to date which is what I really like about this conference. Is this specific one is the fact that we do see an evolution of a disease and a terminology and a set of studies that we didn't have 15 years ago. And I want to hand it back to Dr. Baxi, and you could tell us where you went from here.
So I will kind of talk a little about how I kind of approach it, and I'll tell you kind of what happened and what I ended up doing here. Keep the mystery up. And I want to just remind again, we started this as 15 years ago, and as was alluded to already, 15 years ago, or even not too long ago, we would have called this thin basement membrane, and that's actually what it was signed out, appropriately so at that point. And this is from the expert opinion back in 2013. So, and this is how you approach patients who had what looked like, microscopic hematuria, and you would go through it. Do they have any family history, which we did not. Were there any other extrarenal manifestations? No, there were not. If there were, that kind of goes to more of a Alport's, and if everything else is negative, then you're kind of going down that thin basement membrane nephropathy. Typically, these patients, when they had a kidney biopsy, they just had diffuse thinning. They had normal alpha 3, alpha 5, just as our patient. And unfortunately, when genetic testing, even 10 years ago, this was quite difficult. Genetic testing was kind of a thought of the future. So many of our patients did not get that. These we thought of as primarily benign course for the most part, nothing else to do. If they have blood pressure issues, put them on ACE inhibitor or ARB, reduce the proteinuria, control other factors that you can. And I think this is why I pulled this from the paper. It's interesting. And now looking back at it with this case, you can see how much has changed. And, Alport should be reserved for only patients with characteristic features of a type 4 collagen abnormality, either in COL-A5, the alpha 5, or the alpha A3 or A4 gene, that code the alpha subunits. And thin basement nephropathy should be reserved for individuals who have persistent isolated glomerular hematuria, as is our case. Now, we also knew at that point we had patients who had subset of these thin basement membrane patients without going those papers that had proteinuria. And we just thought, okay, well, it's just a subset, small minority of these patients. How much has evolved in the course of, I guess that's, last 5 years ago, and 5 years ago, then we have a new guideline that kind of came on. This is what everyone was kind of referring to, is this new classification of how we approach these patients with Alports. And within that, we've kind of encompassed patients who previously we said thin basement membrane disease, and now the nomenclature really is to go away from that term, almost just as we say a pattern injury, that's just a pattern injury, not a disease, and kind of looking more at other aspects of that, what causes that pattern injury. So this is from the most recent consensus from, like I said, 2018. We look at Alport's patients as, again, X-linked and autosomal, which we had before. And just to recall, X-link again, these are patients who have the COL4A5 gene mutated, which encodes the alpha 5 subunit of type 4 collagen. And these patients, again, X-linked, so males will have, a quite high risk of ESRD, 100%. Women, again, because of random X inactivation, it's very variable. They can have severe disease. But again, it's not as bad as when you have a man with X-linked, and that's just from random X inactivation. Autosomal recessive and dominant. Autosomal recessive, again, very high rate of progression to ESRD, usually pretty early, as similar to X-link. And then at that point, the least common or in prevalence that was thought was dominant. And these patients now are subcategorized as having, these patients have either, a gene in either alpha 3, A3 or A4 gene, which encodes alpha 3 or alpha 4. And if you have one abnormal mutation there, typically patients can have really less progression than the autosomal recessive and X-linked counterparts. And these are the patients which were previously that we would mention, which we designated as thin basement membrane disease. They would fall into this category. And as I think Dr. Corbett mentioned, the point of that was that many of these patients who were previously with thin basement membrane disease, automatically were thought to have a very benign course, and that's not the case. Some of these patients can have progression or really have what we would now call autosomal dominant Alports, even though they can still progress. And these patients were previously categorized as thin basement membrane. The one that I really didn't understand greatly until I had to look up this case was this Digenic, and this was brought up by multiple people already. So I want to go over this a little more, but at the basics of it, I think the next slide kind of shows that, is what is Digenic disease? It basically refers to two pathogenic variants at different genes. And we're specifically focusing on these three genes, the call A3 to A5. And so digenic means that you have two different variants at the two different loci. So different than our typical Mendelian genetics, these follow non-Mendelian genetics. And it's thought that the variants at the two spots can explain the phenotype of some affected individuals better than a variant in a single locus. So having two different types of mutations and the effect of both together is somewhat different than just having one individually. And I don't go into this, but there's different types of mutations at these genes as well. There's some that are more severe mutations versus some mutations at these genes that are less severe, and that also affects your phenotype. So the genetics here is quite important, and I think that's really how to approach this case. There are other diseases that have this type of digenic inheritance. Some that I'm not really aware of. A lot of these do have other, neurosensible hearing loss, deafness, etc. There's something called Usher syndrome, which I didn't know about. I only know one Usher, but this is a completely different Usher syndrome. So I don't know if anyone knows about that, but this is not unknown in genetics, but it's something relatively new in our understanding of Alport syndrome. So going back to the digenic aspects of this. So if someone has a digenic Alports, they would have a mutation in either A3 or A4 or A5 as a combination. So they can have either A5 plus A4, A5 plus A3, or have A3 plus A4 mutations. And they can either be in trans or in cis, so either on the same chromosome, same chromosome or opposite chromosome, and that also affects your phenotype as well. So typically when you have a mutation in the the A5, which encodes the alpha 5 subunit, that usually is much more severe, and I'll go into that. And this is all from that the paper the 2022 review, which was quite nice. So quickly, we had showed the immunofluorescence, and I think this is good to review. Just looking at normal patients without Alports and the immunofluorescence and the kidney biopsy of patients who do. So this is a patient who has X-linked. So typically your alpha-3, alpha-4, alpha-5 should light up, and this is normal. In a man who has X-linked Alports, which has really no production of the alpha-5 subunit, these membranes are made up of alpha-3, alpha-4, alpha-5 trimers. So this is all negative. So if you see this patient, this is basically what you would see in someone who has X-linked, in a man who has X-linked Alports. Now, as I mentioned before, in women, it's a little different because you have random X inactivation. And so I think Dr. Corbett was alluding to, is there a little mosaic pattern, which we didn't really see, but this is kind of, you can see there's patchy areas. And this is just due to, again, randomness, where some areas are affected, some aren't. So this is what you would kind of see in a patient, in a woman who has X-linked Alport syndrome. So looking at this immunofluorescence on the biopsy does give us clues to the genetics. This is now looking at the autosomal recessive form of Alports. Again, in normal, all 3 alpha subunits of the type 4 collagen should light up. In a patient who has autosomal recessive, again, those are typically in alpha-3 and alpha-4, you would see alpha-3, alpha-4 negative, right? So this is the glomerulus, both negative. Now, what does light up in these patients, if they only have alpha-3, alpha-4 recessive, is the Bowman's capsule and the tubules, because these can have trimers of alpha-5, alpha-6. And so if you have, these patients have a preserved alpha-5, although they can't form these trimers of alpha-3, alpha-4, alpha-5, they can form the Bowman's capsule and the tubule membrane. So that's another clue that someone would have autosomal recessive versus not X-linked. So if that's not enough, this was me as I was reading this last night. This is that paper that Dr. Corbett referenced, the 22 review in CJason. And this is going over why is it important? And it goes to the question, why genetic testing would be important? Well, yeah, it gives us an idea. It's important for transplant purposes. I also think it's important for family and family planning. This patient has 2 children, and knowing the inheritance can have significant consequences for offspring and their offspring, especially in terms of how these are transmitted. So this is there's 3 different forms, again, of digenic Alports, like I mentioned. One is with, if you have the alpha-5 affected plus 4 or 3, or you have a 3 and a 4, or a 4, so through a combination of 3. So this is just alpha-5 plus the alpha-3 or alpha-4. So if you just have alpha-5, like an X-link, 100% of your trimers are going to be affected because you get 1 X chromosome and you can't really form the trimer that makes up the type 4 collagen of the base membrane. As if you have a heterozygote mutation in A3 or A4, which encodes alpha-3, alpha-4, then you should have 1 normal chromosome, and these are on chromosome 2. So that should be normal. So you still have 50 wild type or normal trimers, but you have 50% affected. So in the digenic form, if you now have a homozygous A5 mutation, which is on chromosome X, and then a 3 or a 4, then 100% again will be affected because of the 50, this wild type is now affected as well, right? So these, not surprisingly, follow a very kidney survival path of those who have X-linked. And so although it's not worse than the X-linked, it's quite similar. Now looking at it, go ahead, sorry.
So help me out here. Digenic means you've got one abnormal alpha-3 and 1 abnormal alpha-4, or 3 and a 5, or any of those.
Yeah, so in this case it would be a 3 and a, they use 3 and a 5. Yeah.
2 separate genes.
So why can't you have from each parent? Because my understanding for Alport, there's thousands of mutations.
Mm-hmm.
Why can't one parent give you an abnormal alpha-3 and another parent give you an abnormal alpha-3?
That's he's already shown that. That gets back to the other. That's not digenic then. That falls into the autosomal recessive or autosomal dominant.
But if it's a different, I'm not saying it's a different gene. It's a different mutation. 2 different mutations, one from each parent, but of the same alpha subset.
So you're meaning that you get 2, let's say alpha-3 2 A3 mutations that are different
mutations. You get a mutation for your parent that's an alpha-3, and your other parent has an alpha-3. But there's thousands of mutations apparently in this whole Alport syndrome. And so you get one of each. Is that been described, or?
That's autosomal recessive. That would fall into autosomal
No,
recessive.
but I know what
Autosomal
Roger's,
dominant. Sorry, that would be autosomal dominant or recessive or dominant, depending on the mutation. So I
well,
mean,
Roger, I think is getting at, it could have been one amino acid in one alpha 3 in one parent and another amino acid in the other from alpha 3. And so it's the alpha 3 mutation, but each of the mutations of alpha 3 are slightly different. Apparently, I've not seen anything that distinguishes that. Same thing
although there are
comes up.
there's some mutations that are more severe, like nonsense mutations. Those are more severe typically than the missense ones. But it also depends on the type of mutation. But even if you got those, and I think that this was said in the chat, that would be characterized as a heterozygous. So you have two different autosomal recessive.
And I think that's what Dr. Friedman is saying, that he said, wouldn't this be a compound heterozygous autosomal recessive? So, you know, once again, I'm learning from the audience. So
I mean, that's another way to look at it, right? I
Yeah.
mean, we've talked about that in other things like Potosin, and with multiple different abnormalities that lead to podocyte dysfunction. In a way, this is a compound heterozygous. It's just that they refer to it this way. You know, it's kind of
Got it.
interesting.
Yeah.
But the whole issue of cis and trans, I thought was very interesting as well. I mean, one parent can give you two abnormals on the same chromosome. I mean, these both alpha 3 and 4 are on chromosome 2. And so if they're cis, it's like an autosomal dominant, but that's only coming from one parent. If it's trans, then it's got to come one from each parent, and one's an alpha 3, one's an alpha 4, or even in this case, X-linked. But I think as Pravir shows you, the X-linked trumps everything. It doesn't matter if you have X-linked plus an alpha 3 or an alpha 4 mutation. It doesn't get any worse generally if you've already got the X-linked.
Yeah, which is the A5 gene that encodes alpha 5.
Right.
So in the kind of the way to look at it, Roger, is, I mean, you had two patients who were women who had X-linked and they both ended up on dialysis. Maybe even though they had a mosaic, maybe they could have had a more severe mutation in the A5. And that's why they had a much more severe phenotype resulting in ESRD versus the general thought that, oh, maybe women don't progress as quickly as men who have X-linked. That's the way, at least I would, that's how I thought about it. Now, this is very similar. This is women. Again, if the only difference is here is, again, it adds another element of, there's another element because you have now random X activation. So, you know, if you have a 5 mutation plus a 3 or a 4, you do have a normal A5 gene on the other X chromosome. So you do have some wild type or normal type 4 collagen. And, you know, there is a trend of less proteinuria in these patients, probably as a result of that. But you know, overall, you can see that the X-linked or the A5 variant is still is much more, you know, worse. This is what comes back to, now this is the one that's what was kind of mentioned here, is if you have an A3 and A4. So if you have an A3 and an A4 gene mutation, so what that means is that, you know, you have a digenic disease, and again, it does depend on the type of mutation, and some are severe and some are not as severe, but in this scenario, you will have only 25% still of normal type 4, alpha 3, alpha 4, alpha 5 trimers, and the rest are affected because of this. And when you look at these variants as opposed to the heterozygous variants versus the autosomal recessive, these fall somewhere in between. Again, they're not as bad as the autosomal recessive because they have some wild type, but they're not as good as the heterozygous variants because they have likely 2 gene mutations. But again, this also depends on type of mutation. Like you mentioned, there's hundreds of different variations of this. And so I think that's the biggest thing from that paper. It's a really good paper. I encourage everyone to look at it. I had to read it a couple times and I'll probably read it again. So if you're like this, hopefully you're not. This was still me, so I read it again. But what does that mean? You know, what does that mean for our case? So what I ended up doing is I of course, I repeated the serological workup. She was young, you know, proteinuria is worsening. So I did a repeat serological workup, and sure enough, everything was negative or normal. She never had COVID to explain any worsening proteinuria. And, you know, I thought about doing another kidney biopsy, and because the proteinuria was getting worse, could she have something else? Could there have been IgA now? Again, that was there. She still had the hematuria. And the patient was really against doing another kidney biopsy. I had maxed out her ACE inhibitor. So finally I got over to, you know, let's do genetic testing. Much more readily available, easier to do. Cost is much more appropriate. And sure enough, this is what I got. So she ends up having 2 mutations, one in the COL-A4 gene and one in the COL-A3 gene. And so how basically this would fit into what we call a Digenic Alport syndrome. This would fall into having 2 different things. So even in these patients, you can have still some normal wild type alpha 3, alpha 4, alpha 5. So your immunofluorescence can still be positive. So in a positive alpha 3 and alpha 5 on the immunofluorescence on kidney biopsy still does not rule out these gene mutations in these. And I think this was mentioned, and this kind of goes towards the spectrum of, you know, why we've changed this instead of saying thin basement membrane to Alports, because she does have proteinuria. And I suspect that, you know, that is not because she was a variant of thin basement membrane, because she actually has Alports, and it's just it's a digenic one. So
You know, can I ask something here? Because as I remember the immunofluorescence, it was definitely positive, but it didn't blow me away. Is there any possibility that that actually is reflecting what you're saying, that there is some normal type 3 and 4 collagen?
I don't think you get, and David, I don't know if David's on, I don't think you get mosaic in these outside of X-linked, right? I mean, I think there's enough.
Yeah, I don't mean mosaic. I mean, it just is brighter. It just seems like it could be a little brighter. I don't know. Maybe I'm thinking too much, but
This is normal. I've only seen one mosaic in my 15 years looking at this, and that was a outside case for that Dr. Corbett saw for consultation. So we
And that's
have
what
yet
looks like
to
something
see
like
a
this.
rush patient present with this.
I wasn't really referring to mosaic. I was just saying that the intensity of the staining, but that's okay.
I mean, what you don't know is whether these 2 mutations that are being found in this patient are on the same chromosome, or if they're 2 different ones. I don't know. I don't know how if they have to do some sort of karyotyping to figure it out, but you don't know.
My guess would be, and this goes maybe because our mother and father both had hematuria proteinuria, my assumption is it's going to be trans, because each chromosome, she would be getting 1 chromosome from each. But
that makes a lot of sense.
Yep.
That's a really
So,
good point.
And in terms of, and so it would be more of a trans, which means, you know, again, so not surprising that, you know, I'm still, you know, these patients do still, you know, she's 40 now, 15 years later, but you know, at least I know. And so with this, what I did next was went to ASN communities, just giving a short segue to that. ASN.
Pravir, I'm sorry, but it's interesting. Normally we're saying that you would do genetic testing in lieu of the kidney biopsy because they're they can give you the information you need. But in this case, the genetic testing actually gave you more information than what the kidney biopsy had. It actually gave you a better diagnosis, and that's not really described that often, I think. And in this case, the kidney biopsy was almost completely useless, because it kind of, you know, at that time, 15 years ago, that's what we had. But now, knowing this, the kidney biopsy kind of showed nothing, but this shows your dimeric, and so that's very interesting. It's almost, I don't think there's that many times where we have genetic testing giving you more information than the tissue.
Yeah,
I think that's a really good point, Bill.
I'm glad she didn't want the kidney biopsy, because it would have been a waste. She still wouldn't need genetic testing. So, you know, if you're confused, I was confused, and unfortunately, Dr. Glassick is not on today, but I did post this on ASN communities. You can just go and see, you know, even then the confusion between, you know, what should this be called, and the different terminology, and maybe we should call it type 4 collagenopathy. This is evolving, and I think we will continue as we see more cases and more genetics get done. We'll see more of this, and it'll make a little more sense. There's not a lot of patients with this subgroup of digenic Alports, but it is growing. And our patient, and this is Dr. Weinstock, who is part of the Alport Syndrome Foundation, basically said exactly, you know, this is a digenic Alport syndrome, and this would be, this is how it would be characterized. And so this is quite cool. I think it does have implications. I referred her to genetics. She has 2 kids. And again, I think this is important. I think coming what Dr. Whittier said is that some of the important points or take-home points for me was, that it's just if you see immunofluorescence staining of alpha-3 that's normal, does not exclude a mutation. Understanding the new Alport syndrome and this Digenic inheritance, which was new to me. And then really another separate, just the importance of genetic testing, and definitely not every single patient needs it, but I think there's many patients out there which have there's a role of genetic testing that, although may not change management just yet, this did help me for her to get a better diagnosis, and also to segue into, the clinical registry where there are for Alports such as these patients, and hopefully if she's interested in doing clinical trials. I think that's the only way we're going to advance, this disease. At least we don't have any treatments yet outside of ACE inhibitors. There's no data for SGLT2 inhibitor, but I did prescribe that as well. I'm still waiting for the follow-up after doing that if the proteinuria decreased, but otherwise really have nothing else to offer, I think. But as I mentioned, it does have implications for transplant in the future. Fortunately, I think she will. She's been normal preserved eGFR for 15 years, which hopefully is a good long-term prognosis, but I guess time will tell.
If you would have told me she got 3 points or 2.6 grams of proteinuria 15 years ago, I would not have predicted that she would have a normal creatinine now, and that she wouldn't really have changed. She only gone to 3.5 grams. So she's clearly done better than I thought she would have done, but that doesn't change anything. It's just, I want to ask a question here. I think the story has become over and over again in this conference. Genetic testing might be, and even serologic testing for things like PLA2R, we're becoming more precise in our non-biopsy being able to diagnose certain disorders. And so it's been made here that if we done a genetic testing, we might have avoided biopsy. What about the possibility? Dr. Corbett brought this up earlier. IgA nephropathy, there's a high incidence of thin basement membrane for whatever reason that is. So let's say you have a patient that presents like this, and you get back that she has alpha 3 to 5 mutation, and you assume that this is some form of Alports, but she could also have IgA nephropathy. And there is some implication there, because you might actually treat the patient progresses and you just think they've got some bad genes. Whereas maybe if this patient did have IgA on top of it, you might put this patient on steroids or something like that. So, the last thing I want to do is throw a wrench into the really, really wonderful new paradigm of genetic testing. But I don't know that a biopsy is completely out, but I don't know either. I'll have to see what we do going forward. Because, isn't it something like 30% of people, or Steve,
No, I said it was like 20-25% or so of IgAs will have thin basement membrane.
That's not insignificant.
No, I know. I actually have a young lady that I follow right now who has exactly that. I actually have another patient who had myeloma-associated, renal disease, amyloid with thin basement membranes. If you want to, so it's kind of interesting how you see thin basement membranes with a number of things, and I haven't done genetic testing on either one of them, but I'm thinking about doing it. There's no family history of anything, but especially this young girl, she has no proteinuria whatsoever. She has some microscopic hematuria. I've wrestled with even putting her on an ACE and ARB because she runs low blood pressures as it is, but she has both. And we were talking just recently about just going ahead and doing the genetic testing out of curiosity. Neither parent has any kind of hematuria whatsoever. But yes, I mean, there's a literature out there of IgA patients who have thin basement membrane coexisting.
I think the other big point I put in here, I forgot to mention, is FSGS. There is association of, some of these A3, A4 genes in patients who have just biopsy FSGS pattern or injury. And, if you see that, there's a trend, if you just see FSGS pattern or injury, really no other major kind of explanation for it. These could have underlying A3, A4 mutations. So there's a lot of patients who have both Alports plus FSGS. And so I think if you see FSGS without anything else, I think genetic testing would be helpful there too.
I mean, there's a European registry for sure for Alports, which has a lot of data. I mean, they're the ones that were the first to show if you start ACEs or ARBs early on, you can really alter the, in fact, even before the proteinuria starts, if you've got that diagnosis of X-linked Alports, you can really alter the course substantially. I don't know of anyone that's actually been following these other mutations per se. And I don't know if the European registry has now included some of these other mutations as opposed to just the X-linked, but it'd be interesting. I don't know, and Pravir, you've probably looked into this, whether there's any registries here I'm only aware of the European one. And then the other thing is did you find any data on SGLT2s in patients who have Alports, or has anyone even looked at adding that to ACEs and ARBs?
But Bill sent an article in the chat with there is hopefully more data coming out, but there is some small he sent something in the chat. A case series of looking at SGLT2.
Yeah, it's not a randomized controlled trial or anything, but there's case series of it.
I think
There's
it's a
two
pretty benign
cases
therapy.
in
It'd be
that
hard not
series.
to.
There's two pure Alports, but the follow-up was 3 months, and one of them, the
Yeah.
proteinuria went up, the other one went down a little bit. So it's just really not,
Right, it's really not known.
yeah.
I think Roger's point is a really good one. I mean, I think that we had the biopsy, which showed that, and then we have the genetic testing, so it's easy to say that we didn't need the biopsy, but you're right. Like if you have this in real time, you're on the biopsy, coexisting IgA could require different treatment.
Yeah, but what if you get a biopsy?
FSGS wouldn't require any different treatment because it'd be a secondary FSGS, but coexisting IgA, maybe you might do, depending on, the severity or how much mesangial stuff is there, or how, you have a hard time figuring out what the proteinuria was due to, if it's a thin basement membrane, or the alpha chain issues or the IgA nephropathy, if there was that much, but you might actually treat IgA with something different than an ACE inhibitor or a closing.
But what if you get the biopsy, you've got these alpha-3, alpha-4 abnormalities can actually be autosomal recessive, autosomal dominant Alports. And all of a sudden you get a biopsy and it's not just thin basement membrane, you start to see the basket weaving and other features that are more consistent with an Alports. Then you've got a whole different bag of worms as far as dealing with it. To just assume that all alpha-3, alpha-4s are going to be consistent with a thin basement membrane-like picture, I think might be an oversimplification. I mean, because as was shown in the new classification from 2018, the Cashinet, those patients that had autosomal recessive, autosomal dominant Alports, which were not the Digenic ones, I think they talked about, lamellation and stuff, the autosomal dominance, because lamellation. So you'll start to see these base membrane changes that are consistent with X-linked Alports.
But what does that mean to you? How does that change?
Well, it means to me that it's not just thin basement membrane. I mean, if you just get thin basement membrane and you've got what this person has, then you could say, well, yeah, this is consistent with just Digenic Alports, if you will. And you don't see these changes in the basement membrane that give you the impression that the prognosis is going to be a lot poorer than just thin basement membrane. You start seeing all these, these abnormalities in the basement membrane, like the lamellation. You have a greater sense, I think, that this is going to progress. Now, granted, you would expect to see that by way of creatinine, but we all know that creatinine is not the best marker of renal function. That the kidneys can compensate fairly well for a while before you start losing function.
The thing is that we don't really have a treatment. So prognostically, yes. But I think your point is that we got to really drop the thin basement membrane nomenclature, because it just makes you think such it's a benign disease, and we need to call this type 4 collagenopathy.
That's the point of all these articles.
And define it, if you can define the genetics and then follow them clinically, and then maybe someday we'll have a therapy. Yeah, type 4 collagenopathy. Yeah, maybe I stole that from Dr. Glassick, but
this is a pattern of injury.
We're going to end that we're going to end every conference with "this is a pattern of injury."
This is a pattern of injury.
It's a pattern of injury, but I got to say that thousands of mutations have been found for these. I mean, thousands. I don't know of any. I'm not a geneticist, but do we know of any other disease that has that many mutations?
Yeah, polycystic kidney disease.
Thousands?
They have. There's a ton of different mutations in chromosome 16 that lead to PKD. I mean, there's a laundry list of them.
I doubt it's 1,000.
Well, okay, maybe not 1,000.
No. I mean, really, think about it. I mean, what's monogenic out there? Sickle cell is monogenic, I believe. And there's all versions of this. But this was a long time ago. I learned this from a pediatric nephrologist that there's thousands. And I was just shocked. And maybe that explains why all the different phenotypes of eye disease, and my woman on dialysis has perfectly normal hearing. I mean, it's like Prabir already brought up. I mean, there's these missense, all these various types of mutations, and and various different amino acids in the same gene. Exactly.
And
no, I get it, but I mean, I'm just saying.
I bet it's millions.
Okay, it's millions.
It's gazillions.
But I suspect it's because type 4 collagen, you can live with a little bit of abnormality, and that if you've got other genes that you have mutations in, that things just don't work, and you don't survive, or it's a much worse problem. But it's just remarkable to me that there could be that many out there. But I'm beating a dead horse. Anybody have any other
Dr.
comments?
Baxi, Dr. Ravi, I have a question for Dr. Baxi. Would you offer her clinical trials?
Yeah, absolutely. And that's what I'm hoping and follow up to discuss with her. I think through the Alport Foundation, there's some clinical trials if she's interested. I think that's definitely the whole point of the other part of this is doing the genetic testing gives us a more genotype, and that does increase our patients in clinical trials. And hopefully one day we will have a treatment for this, or at least
Well,
something that slows progression more than
Well, I
ASAP.
don't disagree for a second that she put in a clinical trial, but having been involved in enough clinical trials, the death of a clinical trial is when you put people in that aren't progressing.
Yeah, that's exactly right.
And she really hasn't progressed. So, you know, you're not going to show anything, help of anything if she's not going to get worse. In 15 years, she's done pretty well. But that's neither here nor there. And I don't know what the trials are looking at. And I think it's absolutely, you know, let them decide if she's appropriate for that. But
By the way, what did Agnes have to offer? I saw Agnes was one of the people that weighed in on the communities. I can't, my eyesight.
Well, she basically said that the naming of spectrum of lesions and diseases caused by abnormalities in collagen type 4 is indeed a challenge. Basically going towards, you know, looking at a syndrome that's constellation of findings. And, you know, microscopic hematuria does not have a syndrome, and kind of going away from this terminology and looking more of, you know, how we've evolved in our naming of ANCA associated vasculitides, kind of like what we've been saying.
She says there's a strong movement to go away from eponyms and rather focus on molecular pathogenesis. Exactly what we've been saying. So
Yeah. Yep.
very interesting. So I'm going to wrap this up. Thank you, everybody. Thanks for joining us. I think we set a new record. I know I set a new record. I'm going to take a shower now because now it's 115 degrees in my office. I can't blame Canada, which we blamed for a while there on for the wildfires. So Dr. Reen, you're off the hook today.
And Mel.
Yes, exactly.
Weather is
Yeah.
great. It's about 70 degrees and sunny.
Yeah, well, thank you.
We
Thank you
have
for telling us.
one of the applicants is, I see, from St. Louis, and having lived in that area, my guess is it's got to be a hell of a lot more humid down there than it is up here right now.
It always is. Well, anyway, thank you, everybody. We'll be back. Keep your eyes open for our emails. If anybody wants to not on their list, to send us a direct message or any of us an email, we'll put you on the mailing list. And please join our YouTube channel. We'll post this up shortly. Great job, Pravir. Great job, audience. You're always smarter than me, and that makes me smarter. So I appreciate it. We'll see you next week, everybody.